diabetes mellitus is one of the most important and most frequently asked topic in community medicine as well as general medicine. In next 10 minutes, keep your focus high and I'll try to explain it from parts in a simple, exam-oriented way using flowcharts and easy concepts. So let's begin. By the end of this video, you will be able to define what is diabetes mellitus, classify it, understand impaired glucose tolerance, understand insulin resistance syndrome, recall the anatomy of pancreas, explain normal glucose uptake into the cells, understand insulin resistance, pathogenesis of diabetes, and understand the clinical features and their mechanisms. Now coming to why are we so concerned about diabetes? Why is diabetes so important? Because it is becoming a major public health concern worldwide because it comes under one of the most common non-communicable disease. It is the major cause of blindness, major cause of chronic kidney disease, major cause of cardiovascular disease. So it is of high public health concern. Now let's dive deep into the diabetes with the definition of diabetes. Diabetes mellitus is a chronic metabolic disorder which is characterized by persistent hyperglycemia. Hyperglycemia means increased in the blood glucose levels resulting from either defect in the insulin secretion, that is like in type 1 diabetes mellitus due to autoimmune attack of the own body cells to the beta cells of the pancreas. There is complete decreased in the insulin secretion and absolute insulin deficiency, so it is also known as insulin dependent diabetes mellitus, that is type 1 diabetes. Whereas if there is defect in the insulin action like in type 2 diabetes, here the beta cells of the pancreas will be normally secreting the insulin, but the released insulin, it should normally the insulin receptors should take up the insulin, and then GLUT4 receptors present on the cells should take the glucose into the cells to produce the ATP. So this is not occurring. So to sum up, it is a metabolic disorder leading to persistent hyperglycemia resulting from defect in insulin secretion or insulin action or both. Now let's understand the normal anatomy of pancreas. Pancreas is divided into two parts, like it is exocrine pancreas and endocrine pancreas. Endocrine pancreas is also called as islets of Langerhans. Normally, exocrine pancreas is mainly concerned with the pancreatic enzymes release that helps in digestion, whereas endocrine pancreas is helpful for the blood glucose level maintenance in our body. So it is having four types of cells. One is alpha cells, beta cells, delta cells, and PP cells. Alpha cells will release glucagon that are responsible to increase the blood glucose levels, whereas beta cells will release the insulin that will decrease the blood glucose levels. So basically glucagon and insulin both are antagonists to each other. Then so in diabetic patient, the pathology or defect lies in there is improper balance between the glucagon release and insulin secretion, either due to defect in insulin secretion or due to defect in insulin action. So the main culprit is beta cells are affected in the pancreas. Now let's understand the normal glucose uptake into the cell. Normally, whenever we take food, the food in the form of glucose enters into the blood when the glucose level raises in the blood, so that it will trigger the pancreas to release beta cells of the pancreas to release the insulin. So that insulin, it should bind with the insulin receptors present on the cell, and that will trigger the GLUT4 receptors which are mainly present on the skeletal muscles and adipose tissue. So these GLUT4 receptors, when they are activated, they will help in uptake of the glucose molecules into the cells. This is the end point and the most important point because after taking up the glucose into the cells only, the body will produce the ATP and the energy will be produced. Whereas in diabetes mellitus, the defect at two main checkpoints, the insulin either it is not released only, so that there is no activation of the GLUT4 receptors, or else if there is release of the insulin as in type 2 diabetes mellitus, but the insulin resistance, the insulin receptors at the point of insulin receptors, they are not taking the insulin into them, so they are not triggering the GLUT4 receptors present on the adipocytes and skeletal muscles, so the glucose won't be taken into the cells, and though no energy uptake. So in either cases we'll get diabetes. Now let's understand the pathogenesis of diabetes. Type 1, as I already said, it is autoimmune, in which the beta cells of the body are distracted by the own immune cells because it is immune mediated destruction. Then all the pancreatic beta cells will be damaged and absolute insulin deficiency leading to hyperglycemia. Whereas in type 2 diabetes mellitus, here there is no such destruction of the beta cells of the pancreas. They are normally functioning, but the insulin secreted, insulin receptors are not taking it up, and there is hyperglycemia. Now coming to gestational diabetes mellitus, due to pregnancy related hormones like progesterone and estrogens, insulin resistance is developing. Again, insulin resistance will cause hyperglycemia. Now let's understand the clinical features of diabetes mellitus. The main 3 P's of diabetes mellitus are polyuria, polydipsia and polyphagia. Polyuria refers to frequent urination. That means why it's occurring is the main reason, because glucose is an osmotically active substance. So osmotically active substance, always they'll drag the water along with it. So whenever we take food, the blood glucose level rises in the diabetic patients. Then when the blood enters into the kidneys for the filtration, there should be normal reuptake of the water, but the glucose is drawing the water along with it, leading to frequent urination. Then due to frequent urination, loss of body fluids leading to frequent thirstiness, so the patient feel polydipsia. Then polyphagia, you might be wondering why the patient is having polyphagia, because already the blood glucose levels are high. The main pathology here to understand is the blood glucose levels are high, but they are not taken up into the cells to produce ATP and generate the ATP. So the main problem lies in the uptake of the glucose into the cells. So the patient, despite eating lot of food, the glucose is not entering into the cells and the patient feel weak. That is the reason for fatigue. Then weight loss, the body thinks that the body is under the starvation and there is degradation of fat and muscle for energy. Now blurring of vision occurs due to osmotic changes in the lens, recurrent infections, because glucose is the main source for lot of bacteria, so they cause infections and immunodepression in diabetic patients. That will also cause delayed wound healing, and pruritus is mainly due to skin dryness and recurrent infections. Now the quick summary is insulin deficiency or insulin resistance leading to hyperglycemia causing polyuria, polydipsia, polyphagia. Now key takeaways from this video are: type 1 diabetes mellitus is also called as insulin dependent diabetes mellitus, which is absolute insulin deficiency. The patient should be on insulin injections. No oral hypoglycemic agents will work. Whereas in type 2 diabetes mellitus, insulin resistance causing beta cell dysfunction. In gestational diabetes, pregnancy is inducing the insulin resistance, and in impaired glucose tolerance, it is a pre-diabetic stage. So now we have understood from the definition till the clinical features. In part 2, we will be learning about the epidemiology, fasting blood glucose levels, postprandial blood glucose levels, HbA1c, screening, prevention. Till then, think about this: what fasting blood glucose value confirms diabetes mellitus, what HbA1c values confirms the diagnosis. We'll answer these questions in part 2. So comment below when should I upload the part 2. If you liked the video, try to share the content with your friends and subscribe this channel, and comment which topic to upload next, either hypertension or rheumatic heart disease. Thank you for patient listening.